echogenicity representing muscles and fascia, and the reverberation artifacts beneath the pleural line imply an underlying air-filled lung. This is known as the bat sign. In a longitudinal view, the bat sign identifies the upper and lower ribs, the wings of the bat, and a little deeper the pleural line is the back of the bat. The normal ribs appear as hyperechoic surfaces with posterior acoustic shadows. Half centimeter below the ribs, the visceral and parietal pleura appear as an echogenic bright line, named the pleural lines. During respiratory movement, the two pleural lines glide with each other and is referred to as the gliding sign. Loss of this sign can be seen in pneumothorax or diffuse pleural thickening. Chest ultrasound depends on sonographic artifacts. They help us in diagnosis. The A-line artifact is the single or multiple horizontal reflections of the pleural interface. They are present in a normal lung as well as in pneumothorax when the lung sliding is lost. They result from intense reflection between the surfaces of contact of soft tissues and air-filled lung. Therefore, their depth is multiplicative of the distance between skin and the pleural line. While the B-line artifact or comma tail artifact, defined as hyperechoic reflections, originate only from and travel perpendicular to the pleural line of the lung. They have a narrow base, form a ray spreading away from the transducer towards the bottom of the screen, and they move synchronously with lung respiration. The V-line is seen in supine patients above the diaphragm in presence of effusion or pleural fluid. The posterior thoracic cage, vertebral bodies, and posterior ribs are seen in echogenic line extending cephal to the diaphragm due to transmission of the ultrasound waves through the fluid. The lung curtain. This term refers to the edge of the normal lung artifact visible at the costopharyngeal angles. On inspiration, the descent of the lung artifact transiently obscures deeper structures such as liver, spleen, and kidneys, like a theater curtain drawn shut to hide the stage behind it. The seashore sign is a dynamic sign of normal lung. We can see it in M mode, described as a complex picture of parallel lines like sea waves representing the static thoracic wall layers, and the granulous pattern like sand below the pleural line represent the normal pulmonary parenchyma. This seashore sign is lost in presence of pneumothorax, and we can see instead the barcode or stratosphere sign. We will see it later. Here is a suggested classification of the thoracic artifacts. They help us in differential diagnosis of different pathologies. At first, when we see an artifact, we should decide, is it at the pleural line or superficial to the pleural line? If it's at the pleural line, horizontal A-line artifacts are present in normal lung, while the other vertical artifacts is comma tail or B-line artifact. If they are short and ill-defined, they are Z-lines. If they are long and reach the bottom of the screen, they are called B-line. The single B-line isolated can be present normally. However, the presence of multiple B-lines is present in interstitial lung disease, in interstitial pulmonary edema, and according to the distance of each B-line, we can divide them into B7 or B3. The B7 is a distance of 7 millimeter, and B3 is a distance of 3 millimeter, and it is used in grading of interstitial tissue affection. However, if the artifact is superficial to the pleural line, it means that it's in chest wall, and it occurs when there is a surgical emphysema, like in E lines or W lines, surgical emphysema or subcutaneous metallic artifact, bullets, shotguns, or whatever. The technique of chest ultrasound. Examination of seated patient with a linear probe placed longitudinal on the right parasternal line. We can see cartilage at point of insertion of the rib, intercostal space, intercostal muscle, and the pleural line. Examination of seated patient with a linear probe placed parallel to the ribs. We can, in the third intercostal space, as for example, we will see intercostal muscle and the line of the pleura. The transhepatic examination with a convex probe placed subcostally from the right with a slight tilting in cranial direction shows the liver diaphragm as well as reflection of the liver above the diaphragm. Here is examination of the lateral aspect with a convex probe. In mid portion of right axillary line, we will see the diaphragm, the normal mobile lung shifting during inspiration into the pharyngeal-costal recess and covering the upper margin of the liver, which is the lung curtain as we described before. We will discuss few of the commonest findings in chest trauma by ultrasound. Chest wall injuries as rib and sternal fractures are widely seen by chest ultrasound. Here we can see a rib fracture, interruption of the cortex of the rib. We can discuss the presence of displacement, overriding, angulation of the rib. We can see also in this image there is comminuted fracture with multiple bone fragments. We can see a chest wall hematoma. Here is a rib fracture with displacement and mild overriding, and an overlying heterogeneously echogenic hematoma can be seen. Also, surgical emphysema. As we discussed before, surgical emphysema appear as E-line artifact. We can see echogenic linear artifact superficial to the pleural line, which represents air under skin or air within the chest wall. Pleural injuries, the most common in post-traumatic patient is the presence of hemothorax. We can see hypoechoic pleural effusion and underlying lung collapse. If it's a long-standing hemothorax, it starts to organize, and we can see septations, and we can see complex encysted component, so it may turn into septated or complex septated pattern. And here's another case of hemothorax. Pneumothorax, as we discussed before, there is the lung sliding or the gliding sign, which represents the sliding of pleural surface over each other. Okay, the transition from the lung sliding of the pleural line into an area where there is no lung sliding is called lung point, and this lung point is pathognomonic for the presence of pneumothorax. The transition from the lung sliding to absence of lung sliding. Also, examination of pneumothorax in M mode. At the left side, we can see the normal seashore sign in M mode, as we described, the static layers of the chest wall and underlying granular pattern, sand-like pattern of the lung parenchyma. However, the presence of air and the pneumothorax within the pleural fluid will overcome the evaluation of the deeper lung structure. So we will see multiple parallel lines as barcode line or barcode sign or stratosphere sign as in the right image. Also, the presence of pneumothorax or mixture we can see as in this patient. We will see hypoechoic pleural fluid and the internal echogenic linear foci. We can also see air fluid level as in this image, the white arrow. Lung injuries in chest ultrasound, we can see superficial lung contusions and lung laceration. It appears as hypoechoic, subpleural, consolidation-like areas. We can see internal air bronchogram. We can see disturbed pleural surface or interruption of the pleural surface. Here on the right side, we can see the white line, the echogenic pleural line. On the left side, we can see there is disruption of the pleural line with some irregularity and hypoechoic areas. These represent subpleural hypoechoic consolidations. And of course, lung collapse. Here is the patient with hemothorax and underlying lung collapse. Collapsed lung appears hypoechoic because it's not filled with air, but we can see multiple hyperechoic linear structures within. This is the air bronchogram, and they are crowded air bronchogram because it's a collapsed lung. Case presentation. Male, 38 years old, with penetrating chest trauma, 2 stabs in the left side of the chest 2 days ago. Here we can see there is a left-sided hemopneumothorax with the partial left lung collapse. In the C image, in the ultrasound examination, we can see that examination, there is loss of the pleural sliding sign, and there is the stratosphere sign in M mode as in the right image. In D, we can see that there is minimal effusion. It starts to be echogenic because the injury is 2 days ago. It starts to be slightly echogenic with septations of the effusion as a start of organization. A male, 41 years old, had a blunt trauma to the chest 2 days ago, presented with severe left-sided chest pain. Here we can see that there is multi-level rib fractures on the left side. There is left-sided hemopneumothorax. And of course, there is subpleural contusions, subpleural consolidation areas with partial lung collapse, and there is surgical emphysema at the left side of the chest wall. In image C, we can see that there is disruption of the pleural line. There is a hemothorax.
For sake of the time, can you wrap your presentation
Yes,
up?
I'm sorry. There is a hemothorax, a subpleural consolidation with a crowded air bronchogram. In image D, we can see also the stratosphere sign, which represents absence of pleural sliding in M mode. And in image E, we can see that there is a pleural float in the costopharyngeal recess. And in image F, we can see that there is a rib fracture and a chest wall hematoma, small hematoma at the fracture edges. Female 2.5 years, bronchotrauma to the chest 1 week ago. Here we can see that there is a right hemothoracic veiling, patchy consolidation, the upper and mid zone with reduced volume. We can see that there is a right-sided chest tube, misplaced or displaced right-sided chest tube with subpleural consolidation and right-sided hemothorax. And within the consolidation, there is cavitary changes, early cavitary changes. In ultrasound examination, we could see that there is right-sided hemothorax. Internal air locules represents minimal internal pneumothorax. And in the image G, we can see the collapsed lung parenchyma with internal cavitary lesion showing air locule and air fluid level. This is either early abscess formation or complicated lung laceration. So it starts to appear as a cavitary lesion. Male 5 years, multiple.
Can you go to conclusion, please? Conclusion.
Okay.
Yes.
The chest wall lesions as ribosternal fractures can be better detected by chest ultrasound, especially in the acute post-traumatic period in comparison with chest X-ray. In ultrasound, we can see the muscular and subcutaneous hematomas. Chest ultrasound is important in detection of pleural effusion hemothorax, even minimal amounts. An ultrasound can be detected. Similarly, chest ultrasound important diagnosis of pneumothorax in comparison with X-ray. However, of course, the CT chest has the upper hand, and chest ultrasound important in diagnostic of superficial lung consolidation, lung contusions, and laceration. They are superficial, so they can be detected. However, deeper structures are better detected by CT. Of course, we recommend the use of ultrasound in post-operative patients, ICU patient, and post-traumatic follow-up, and it's safe, no radiological exposure, ionizing radiation. So that's our recommendation. Thank you.
Thank you, Nora.
Thank you, Dr. Dina, for her excellent and important presentation. Next speaker is Professor Hatem Al-Hazizi, our dear friend. The topic will be dynamic ultrasonography, a tool for usual and unusual disorders.
صباح الخير. One of the most important diagnostic advantages of ultrasound over other imaging modalities is real time, allowing us to have a dynamic evaluation. This in musculoskeletal ultrasound in some pathologies can be the only